Morning, everyone. Can you hear me all right? Well, thank you for this great opportunity, and we just wanted to take you through our experience in Oxford and Oxfordshire of our little department's view on teledermatology. So I was just going to talk a bit about the surrounding area, put us into context, and why our teledermatology now is for us so vital, and just take you through what it's like from the perspectives of different service users, both our GPs and our general physicians who ask us, as well as a dermatology consultant who receives the emails. But we also use a large part of our data for training purposes, both our specialty registrars like myself, as well as the GPs themselves who email in. And then we've got a little registrar-led system where we can pretend to be one of the big boys and practice for ourselves internally. So for those of you who don't know Oxford, we're nestled in South England, a big centre for research, the universities, and a big tourist centre. And we're just down here. And our county covers roughly about 30 by 70 kilometres. And the city itself in the centre, but the rest of the population is spread out around the cities and various towns. And the city itself, without the students, would have a population of about 160,000. And the county that we serve would be somewhere under 700,000. And we're fortunate enough to be one of the more affluent areas in England and have one extra general practitioner per 10,000 of the population, as you can see. And the department sees 40,000, let's say, handshake clinic patients a year, and the demand's been rising over time. And despite being an affluent area, we are finding that people don't like coming to the hospital. It's arduous, it's a very old town, the council's put down strict limits that they're not going to expand the road and arterial network. So it's not surprising that people want a quicker answer without the repeated visits to hospital. And in England, some of you may not know that we have an issue with matching dermatologist demand with the training, and there's a bit of a bottleneck where we have to start thinking a bit laterally. And in 1999, one of our consultants, Dr. Turner, thought that a lot of the routine questions that were coming through may not necessarily need to wait months and months to answer. And he set up an email service himself for local GPs to email in questions with a picture. And over time, that's ballooned to the point that by 2007, they acknowledged that this is something the local primary care trusts were happy to pay per question, and we were commissioned. And so at a glance, this service is open to all GPs in Oxfordshire. The aim is it's for routine clinical inquiries, but in practice, anything can come through and you'd get a straightforward response if it's something urgent about what you'd need to do. A single email address that's covered all days of the week, and usually you're going to get a response within 24 hours. And we keep track of things mainly with our national identifier, the NHS number, which is unique to each patient regardless of where they move in the UK. And photographs are essential. So if you're a GP, someone's going to come with you to you with a skin issue, and if you don't know about it, you would normally send them away with some advice saying, I'm going to obtain some information, can I take a non-identifiable photo? And we've repeatedly said, and in the email acknowledgement, we ask them to take consent for teaching an audit, which most people are happy. Most of our photos aren't identifiable anyway. The GP normally gets a response within 24 hours, and it's one of either advice and reassurance, refer in via a particular pathway, cancer, routine, and once or twice a week we get something that really shouldn't have been photoed in, and we just say, can you pick up the phone and call the on-call registrar to come in? And the onus goes back to the GP with the reply to do that. We do charge per email for this service, and it's roughly a third of the outpatient new dermatology referral. And if you're the dermatologist, you can be doing your normal clinics, and usually you'll be allocated 1 or 2 hours in your job plan and be either 1 day a week or you'd have to cover the Friday and the weekend. Thankfully, you can do it from work or home, and sometimes after a busy day, many of the consultants choose to do it from home. And you get in an email, picture, NHS number, usually a brief history, and sometimes dermoscopic, sometimes not pictures, and you give following advice just like we spoke about. There are downsides, and sometimes you get questionable histories, no pictures, forgotten attachments, just like all the email mistakes we all make. And it's just a reply requesting modification. You don't get charged for that. And emails are all replied to. And if you're a consultant going on holiday, you don't have to worry about someone covering your day, because it's usually allocated automatically to the person covering the next day. So things will get picked up. And we don't delete anything. Outlook archives, and we store it on our secure hospital servers. The consultants were quite keen. We talk about drawbacks at this time. And I think just like we spoke about before, the picture and their quality, sometimes they're second-hand pictures from the patient emailing the GP, backhand selfie you can see, to their GP who comes to us. We don't always get the particular information bits we want in a history, and there's no immediate way of either getting through to the patient, and it's usually an email reply back to the GP requesting further information. It is time consuming. Despite being in our job plan for 2 to 3 hours a day, most consultants find that they usually end up doing it at the end of the day or when they get home. We do get regular instances of patients still being referred in despite reassurance. And when they do come in, we've found, given it's an email-based system, that there's poor linkage with the electronic patient record, which is a difficult software to use in our hospital at the best of times. And like anywhere, we've had instances with a wrong diagnosis that would have come back a bit of time later. Now, with this large amount of data, particularly, you're getting 200-300 referrals a month. There's a big resource there for training both our registrars and the GPs, as we talk about. So we've got a weekly compulsory teaching where 7 or 8 juniors would come. We talk through the cases and managements, usually from a few days before. And normally a couple of emails would come in at the same time that we practice dictating to as Dr. Turner types. And part of the aim is to teach our trainees about modern service delivery and the uncertainty of technology, but to embrace it, because at some point most of us are going to have to use teledermatology, and how to make decisions with limited information. A lot of us find that it's really beneficial for seeing GP presentations that we won't always see in hospital, and be they minor things, but with different questions that GPs may have on managements that we wouldn't have necessarily thought about. And for the GPs themselves who email in, we run a once a month skin club, we call it. So it's a 3-hour meeting that a drug company sponsors kindly food for the evening, and the GPs from the whole catchment area are invited. Many come who've emailed in, and they automatically engage because they can see the pictures they've taken themselves, and automatically get interaction from the audience. And it's usually about 200 to 300 pictures that we go through. 2 consultants present the cases, and there's interaction, and it's an open floor discussion. And over time, we've had growing numbers, and the GPs quite like it, particularly for their training portfolio. And again, they get to see the difficulties their colleagues have and the kind of things that are being referred in, and learn from quite a few presentations in a short bit of time. And the feedback's been great. So they're very thankful that we put it on and feel extremely lucky. And just like any classroom environment, there are some people who will answer a few more questions that we regularly have to make sure that they let others engage. And the nature of it is whatever comes in that month is probably what's going to be talked about. So you can see some people would say that they want some more teaching in case they missed a particular theme in that month. And the feedback's been very good. This is a survey from about 11 months ago. We haven't done one this year, but in terms of content, how they rate the teaching and relevancy, it's all 80-90% in the good to excellent category. And it's reflected in our referral trends. This is yearly, and for this year it would be somewhere around the 3,500 mark that we haven't completed. Just a bit of housekeeping. So we double report everything. So when it's being prepared by Skin Club, 2 consultants will go through the month's email responses to see if they agree. Quite frequently, if there's something they want to add, they will email the GP to say, these are my thoughts as well. It's not unheard of that colleagues go around internally to discuss difficult cases before they give out their replies. And like I said, there is an auto response at the bottom for the GPs to be reminded that these pictures must be consented for storage, audit and teaching. NHS.net, for those of you who don't know, is a nationally maintained email client. So there's speedy responses. It's run out of London, particularly when issues arise, and it's not as slow and clunky as some of our hospital-based IT departments. The storage is safe, and with the NHS numbers, it makes finding things, and particularly for individual patients across the country, useful. Referral conversion percentage I completed last month shows that 28% of those referred over March came in the subsequent 4 months as a referral. And this was somewhere around the 40% mark in 2014. And in that time, we have seen the CCG gift a lot of new dermatoscopes to the city dermatologists. And the consultants are finding that it's easier to diagnose benign things over the last couple of years where we've declined that they need to be referred in. And for the registrars, there's a similar internal registrar-led system. It's a big hospital, it's across 2 cities, and it's not always practical to get there in time. So if you're someone on the ward, you'd call your hospital photography department, take a picture, fill out an internet pro forma, and it comes through to us. And again, we'd either advise, we go see, or we have the benefit of asking the consultant who's in the adjacent room about what they think. But in complex cases, there's photography on the system where we can do the histopathological correlation later on. So I hope that you've got a bit of a flavour for a service that's been established just to mainly complement our rising workloads. And we've had great satisfaction reports, particularly from the GPs. And we're finding it's a great service tool, particularly for education. Thanks for your time.